kids part. So you know for diabetics who have atherosclerotic disease, you're going to use a high-intensity statin. If they don't have atherosclerotic disease and they're moderate risk, then they're going to use a moderate statin. But pretty much that's it with diabetics. It's either a moderate intensity statin or a high intensity statin. And then it talks about add-ons if you've got, if you can't meet goal. You're not going to use a statin in pregnancy. It's contraindicated. Okay, but let's look at kids. So with kids, family history go a long way. So if the family history of early heart disease, especially in a parent before the age of 55 and a dad, 65 and a mom, then you want to screen those kids soon after diagnosis. Okay. But you see that glucose control is established. That's because their triglycerides will be high if you don't. So getting those, get the blood sugar down to normal, triglycerides will stabilize. It won't affect the cholesterol, but it will affect the triglycerides. Goal there is less than 100. If you look over to treatment, notice diet, of course, would be part of that. But you can use a statin. So when would you use a statin? So when you've got elevated LDLs in kids, so greater than 160 or greater than 130 because they've got risk factors. Okay, so that's fairly aggressive. If family history is negative for cardiovascular disease, then you're going to screen lipids when they are hit puberty. If they're diagnosed like 14, 15, 16, if you're gone through puberty, you're going to do a lipid screen then. Okay. So the more cardiovascular disease is part of the family picture, the more aggressive you're going to be. Okay. All right, aspirin therapy. This one changes almost every year. I think they finally got it simplified enough that most people can deal with it. Secondary prevention always should be on an aspirin, unless there's some reason, some weird reason, and that would be, I can't even think of anything. So aspirin, secondary prevention. Secondary prevention means what? They already have known cardiovascular disease. They've had a heart attack, they've had an angioplasty, they've had a stent placement, they've got unstable angina. If they are aspirin allergic, then they should be on clopidogrel, which is what? Plavix. So how do we classify that drug? Antiplatelet. Okay. 75 milligrams a day. That's what we recommend for those who are using it with atherosclerotic disease. Dual platelet. Remember what dual platelet was? Aspirin and usually clopidogrel. Okay. When did we most commonly use it? Acute coronary disease, acute coronary syndrome, or after a stent placement. So here would be a good time. Just pull that handout back out, look, just reread through it so it kind of sparks your memory. Now, primary is always the problem, when to start it. Because aspirin, it's the bleed potential versus the benefit potential. So you're always weighing that. So the recommendations are based on Framingham risk. So if the risk, if the 10-year risk is greater than 10%, remember those calculators they had? American Heart Association was one of the ones y'all used, where you plugged in like their blood pressure and their gender and what had for ethnic group, all that. Plug it in and it tells you, in 10 years your risk is such and such. So if it's 10% or greater, they should be on an aspirin because they're high risk. 10%, the chance of 1 out of 10 in the next 10 years that you'll have some event is considered high. That is going to be common in most people who are 50 and over and have at least one other major risk factor. So if you don't have the calculator and you've got that, they're diabetic and they're over 50, probably need to put them on an aspirin. Now, the problem comes, what do you do with people that are younger than that? I can tell you that in under 30, there's very little data. Under 40, there's not a lot of data. When you get into the 40 to 50 year group, you're going to have to use clinical judgment. If they are really high risk, it might be worth going ahead and putting them on aspirin. Okay. No known heart disease, but very high risk. Maybe there's a strong family history. Maybe they've got multiple risk factors. They smoke, they are very high LDL, they also have, maybe they're also developed albuminuria. So very similar to what you've already learned. Hypertension is pretty much the same. Whatever Dr. Britton taught you is probably going to be exactly what we're going to see here. Measure blood pressure every time. Have they talked to you about how you, can you bill like a level 3, level 4s, have they talked to you about that? No. So when you see somebody, you will bill a certain level. So level 1s, your nurses would do that. Level 2s, you can do a level 2, but they're very low reimbursement. Most primary care are going to do like a level 3. Your specialists are always going to do level 5s. Well, in order to build a level, you have to justify so many elements. So many organs have been done, and so many things have been documented. Well, blood pressure always goes to one of those elements. That's why every time you go in, you're always weighed and your blood pressure is taken, because that's 2 elements off the table. Okay? And you have to do like 9 elements in 3 or 4 organ systems just to do a level 3. So every time you're going to do their blood pressure, and you're going to look for people who've got blood pressure above 140/90. If you look at the next page, it's probably easier. This is a nice flow diagram. And you're looking at people who've got blood pressures between 140/90 and 160/100. And then you're looking at those that are 160/100 and greater. Okay. So starting with 1 drug versus 2 or more drugs. Do they have albuminuria or not? Because that would move you towards an ACE or an ARB. And then adding drugs, continuing that category, diuretic, calcium channel blocker. Okay. I'm assuming this is familiar to you. I'm just going to leave it at that. Work through that diagram. Know those endpoints. So mostly we want their blood pressure below 140/90. If we can get it below 130/80, even better. Okay, might be harder in your older patients. For kids, this is what I think. For children, you're going to measure their blood pressure. They have these little pediatric cuffs. They're really cute. So here they're looking at, instead of a number, they look at percentiles. So if they are above the 90th percentile for age, sex, and height, then you're going to treat. You can use ACE inhibitors in them. You'll see data that says that they're contraindicated or should not be used, and that's because of effects on cartilage. That is found to be, yes, it is a problem. It can be a problem, but it's not very common. And the benefit outweighs the risk. So an ACE inhibitor or an ARB would be initial treatment for a child. So know that. If you're dealing with that age group, that's the time, as they're getting close to puberty, is to talk to them about reproductive or the impact of their diabetes on pregnancy, and the need to plan, and the need to sexual practices and things like that. They need to start to hear that very early, so it will just be commonplace. That's the way they will think. Okay, when I decide to have a baby, I will plan it. I will talk to people, and I will have it planned out so that I will have a beautiful baby and a safe pregnancy. Goal of treatment is below the 90th percentile for their age, sex, and height. Immunizations. You've heard this before. They need a flu shot every year. They're at high risk. They're one of those high-risk categories. Everybody needs it. Should be vaccinated every year. Pneumovax and the Prevnar, both of them. Prevnar is usually preferred first if the other one hasn't been given. If not, either one. You just want them in. Remember, they have to have about a year apart. So you're not going to give them one visits back to back unless you see them a year apart. So those are the 3 that are recommended. Other recommendations are coronary heart disease. It's being aggressive with that. It's paying attention. If they have coronary artery disease, is to making sure that they have the drugs on board that are usually recommended. So we're going to pay attention to their lipids, to their platelets, and to their blood pressure. So an ACE inhibitor, aspirin, statins. And if there's contraindication to those, then you use the second lines. Next page, TZDs, if they have heart failure, avoid the TZD. Pioglitazone is the only one that I gave you. The other one is metformin can be used. Metformin has good cardiovascular impact as long as their kidneys, they meet the criteria for kidney renal use. Glycemic control in children, I think I've hit all this already. So the A1C goal, you should know. You should know the screening for thyroid and for celiac disease. Under hypothyroidism, it's the TPO and the thyroglobulin antibody. You should know those. You should know those 2. That would be a good lab medicine question. You're going to monitor their TSH. We'll get to that more in thyroid. If their TSH goes up, you'd get a T4. So TSH can be your screen. And then get a T4. Celiac disease, you can certainly do antibodies. But again, if during the course of their life they develop a more failure to thrive, can't gain weight, and have the GI symptoms, the other would be to screen. Smoking cessation, we don't want them to smoke, so always be talking to them about that. Remember I told you 50% of smokers said their doctor never said don't smoke? Okay. So don't be in that category. Tell them. Are you smoking? Yes. Have you thought about quitting? No. Well, would you ever consider quitting? I just keep it going until you're like, Okay, preconception planning. This is really important. I'll give you more of the data here. The problem is that preconception planning is important because the time when the congenital anomalies develop are 4 to 8 weeks. And at first trimester, that's when organogenesis takes place. That's when the most anomalies will occur due to a high sugar. Elevated sugars cause anomalies. The higher the level, the more likely an anomaly. The higher the level, the more likely a failed pregnancy. And I'm talking about level as A1C. So starting that conversation early. Women who are, if you look at F, women who are planning a pregnancy, be evaluated for retinopathy. We talked about screened ahead of time, screened during pregnancy. Kidneys evaluated ahead of time. Neuropathy, cardiovascular disease. So the rate of MI can go up. So you can have women who've had disease for 30, 35 years, could be in their early or late 30s, wanting to become pregnant. They can have significant vascular disease already. So those things would need to be evaluated if they've waited later in life to have to become pregnant. Remember, statins and ACE inhibitors, ARBs, are contraindicated in pregnancy. Okay. I think I have downloaded most of the things I know about diabetes this week. You've been good to listen. Okay, yes.
So on this one, you don't have anything starred or asterisk?
Right.
Is it?
I'm not going to ask you tomorrow about that.
Oh, so this is on your, like on your schedule, it said that it was on there, so you take it off.
But I didn't do that, so you're free. But tomorrow, you will have cases of people who have complications.
So what will be on the quiz? Does this some
Does the ones that I've asterisked since your last quiz. So
Treatment of 1, treatment 2, and then insulin injectables.
If there's an asterisk by an objective since that quiz, I'm just afraid I'll miss one and then you'll get it.
So pretty much all my drugs.
I think you missed it. So quiz tomorrow, 8 o'clock, and then the cases. I'll post it. See you tomorrow morning.
Yeah.